some of the testing that we're doing to look at response to treatment and beyond is going to change the face of cancer care.
That's Wendi Waugh from Southern Ohio Medical Center on the future of precision medicine testing. More on that up next. Welcome to the award-winning Cancer Buzz. I'm your host, Summer Johnson. Gastric cancer is a rare disease that's often diagnosed after it has already metastasized, at which point the survival rate drops significantly. Today, we're talking about an emerging biomarker that could be used in treatment planning. That's fibroblast growth factor receptor 2b, or FGFR2b. In today's episode, we get some different perspectives on FGFR2b. An oncologist, a pathologist, and an administrator all tell us how it could impact patients with advanced gastric or gastroesophageal junction, or GEJ adenocarcinoma. First, Dr. Nataliya Uboha. She's an oncologist from the University of Wisconsin Carbon Cancer Center, whose specialty is treating patients with GI cancers.
So FGFR2b is an emerging biomarker. We are not making treatment decision based on this biomarker just yet, but there have been promising data with a drug called bemarituzumab, which is an antibody targeting FGFR2 antibody in patients with this disease. And so we are hoping that as more and more data emerges and as we see the results of the ongoing clinical trials with this drug, that FGFR2b will become an actionable biomarker. And this is something that we'll be able to utilize when we choose treatments for our patients in clinic.
How have you seen the treatment landscape for this disease change?
Biomarkers play a critical role in selecting the best treatment for our patients. And so more and more patients qualify for, we can call it personalized treatments based on unique qualities of their tumors. And so in first-line setting, chemotherapy continues to play a role, and in the United States, we frequently use FOLFOX chemotherapy. But now, depending on what biomarkers are present in patients' tumors, we can add either targeted agents or immunotherapy, which can significantly improve outcomes of our patients.
What are the current NCCN guidelines around biomarker testing for gastric cancer in GEJ?
Biomarker testing is very important when we choose treatments for patients with advanced gastric and GE junction adenocarcinomas. There are several biomarkers that should be done at the time of diagnosis of advanced disease. These include HER2. We test for HER2 with IHC and ISH when needed. PD-L1. We utilize either combined positive score or tumor area positivity TAP score, which is also an IHC biomarker. And this is the biomarker that helps determine whether patients would benefit from anti-PD-1 agents. We also test patients for claudin expression. This is the most recent biomarker. It's another immunohistochemistry biomarker. And then, of course, all patients should be tested for mismatch repair protein expression to determine whether they have potentially microsatellite unstable tumors, as these tumors have significant sensitivity to immune checkpoint inhibitors.
What are the biological and clinical distinctions between FGFR2b protein expression and gene amplification?
So FGFR2 protein expression is evaluated using immunohistochemistry, and it's really the end result of how the gene is functioning and how many proteins the cell produces. It is much more common to see significant expression of FGFR2b in patients with upper GI tumors. About 10 to 15% have significant expression, but it certainly depends where you draw that threshold, what you would consider positive. But FGFR2 gene amplification really looks at the extra copies of the gene that cancer cells have, and that is a much less frequent phenomena that can be encountered in patients with upper GI tumors. And I should have mentioned earlier that in addition to the biomarkers that I mentioned, we typically send patients' tumors for next generation sequencing to look for genetic or alterations in patients' tumors as well, because this is exactly where you could pick up those gene amplifications.
To what extent can those alterations be considered functionally equivalent or surrogate to biomarkers?
It really depends on what therapeutic agent we are using. and how active the agent is. I think when we think that the gene is amplified, that it typically translates into overexpression of the protein. But clearly, you can see overexpression of the protein without gene amplification. So while one, gene amplification can lead to protein overexpression, protein overexpression does not always result from gene amplification. And that's probably why you capture so many more patients when looking at IHC rather than NGS.
We have a multidisciplinary audience, so how does multidisciplinary collaboration help ensure that testing for actionable biomarkers is timely?
Well, it's absolutely essential. We have to work closely with our pathology colleagues to make sure that all of the tests are done quickly and so that they are readily available by the time the patient is seen in clinic. In fact, in my university, in our cancer center, a lot of the immunohistochemistry tests for patients with upper GI tumors are done reflexively. We discussed the recent data with our pathologist, we reviewed all of the biomarkers, and we have outlined which biomarkers should be tested for reflexively without a specific order by a medical oncologist. And so those types of discussions are absolutely essential to be able to get this information quickly.
Wendi Waugh is the Administrative Director of Cancer Services and Ambulatory Infusion at Southern Ohio Medical Center. She's developed strategies to make care coordination a top priority.
So we've done several things, but the things that I think are probably most significant is that we've embedded our biomarker testing into some disease order sets within our EHR. That's been critical to make sure that we have the correct information to go over with our biomarker ordering. I think it's important to establish that we're a small rural community hospital, so we aren't doing any in-house testing. So it's really important that we have that biomarker testing order information up front for our navigator, who is really number two. And so having a biomarker navigator be the interface between the testing company and our oncologist has been another significant care coordination strategy.
Since they work with an external testing company, her team needs to make sure everyone is on the same page.
We have had our pathology manager and our lead pathologist meet in person with the outside laboratory, the primary outside laboratory that we do most of our precision medicine testing with. Just so that they, number one, understand why we're doing some of these things and what that company needs related to the specimen and the processing.
That coordination is front of mind for pathologists as well. Dr. Kristina Matkowskyj is a pathologist at Mayo Clinic. When it comes to sharing the results from pathology with the clinical team, she said having a standardized workflow improves communication.
And so, at least in our practice, what we do is we have a set of guidelines and a standardized reporting form where we go ahead and indicate, what is the particular antibody clone that we're doing, what percentage of cells are staining, what is the intensity of the stain, what is the current cutoff for positivity to report something as positive, because we know, down the road that could change depending on what new data comes out, et cetera. And so we kind of try to standardize that so that our clinicians know what is happening. And if things change down the road, we can go ahead and update that. And so over time, we can see and track what is happening.
She says in order to get results in a timely manner, it's all about getting enough tissue for testing.
As a pathologist, if I was able to stress one thing, it would be to collect as many biopsies as is safely possible for that particular patient. Because, as we know, biomarker testing is evolving. We're seeing more and more biomarkers, and those biomarkers are tissue-based, so immunohistochemistry-based, not necessarily molecular. And so everything is going to be done on that particular tissue. So it's not like we're sending it off, off one tissue section to the molecular lab.
From the pathology perspective, Matkowskyj notes that ordering comprehensive upfront testing can help close care gaps.
What I often recommend is that if we are going to cut the tissue, we might as well cut it and do all of that testing up front. Because if we test only certain things and we stop, we take it off the mechanism, and then a week later find out, oh, all of those tests came back negative. Now we need to do a second round of testing. We put it back. We start cutting into the block. Now we've wasted some tissue. There may not be any more in the block, but that first go around, we might have gotten it. And so as a pathologist, my recommendation is if you're going to order the biomarkers, if you can do it, order it all up front.
And from the administrator perspective, Waugh agrees.
Yeah, I wanted to talk to you about a 50-year-old patient that we had recently that was diagnosed with metastatic junction adenocarcinoma. And at the time of diagnosis, there was comprehensive biomarker testing performed. And the HER2 testing was positive. And so that single result, HER2 testing for this patient, allowed us to add a combination therapy as a first-line treatment. And we were able to do this before chemotherapy was starting, getting some quick medicine for this 50-year-old patient with metastatic cancer. So the patient ultimately responded very well, had fewer side effects than they probably would have experienced with the chemotherapy, and helped them avoid delays. I think, as a key thing, it really enlists confidence in the treatment team. When you can have these kinds of results and you can say, this is what we know we can do for this, and we can get you going immediately on this, really brings loyalty and confidence for the patient population.
And she also says the big lesson here is to plan ahead.
I mentioned earlier about how important it is to integrate the results into your EHR, and tracking and accountability matter. Not only for the 50-year-old GE junction patient that I talked about, but as a whole in your population and for future. So let's say we didn't have anything at the moment for our 50-year-old, but we've been able to do some kind of therapy that advances his life and keeps him going. We don't know that a year from now there's not going to be something. So that tracking, knowing what and when new things go out, being able to mine your data to find those things, I think is going to be uber critical. I believe that the precision medicine testing that we're doing today, and not just the diagnostic testing that we're doing, but some of the testing that we're doing to look at response to treatment and beyond, is going to change the face of cancer care.
Thank you to our guests today. You can check out the show notes for links to resources on FGFR2b and biomarker testing. Until next time, for the Cancer Buzz team, this is Summer Johnson.